Careblazer, how do doctors know whether the brain should be working the way that it should be working? Like, what's normal thinking for the age that they're at, and what is actually dementia? I'm going to be breaking it all down for you today. And I'm specifically talking about neuropsychological testing. It's the testing where somebody is sitting down for several hours, being asked to do tasks like read a string of numbers forward, read them backwards, connect some dots, draw this figure, all kinds of different tasks like that. It's the more comprehensive testing than the 30-question screening that somebody might do in the primary care office or in the neurology office. I'm talking comprehensive neuropsychological testing. How do they really discover what's the difference between normal thinking and dementia? When I used to do this testing myself, so many people in the process of testing would make comments like, what is this even for anyway? This can't tell you anything. Or nobody would get these questions right. Or what does this have to do with, my thinking or my ability to live alone or my ability to drive? And I totally get it, because it doesn't seem clear up front, like, what does this random dots that you connect, what does that have to do with dementia or anything at all? So we could take, for example, have you ever seen the clock drawing test? This is something that a lot of people give, and you might think, what does drawing a clock have to do with anything? Well, here's just a little quick show. Now, it won't take you being a neuropsychologist to realize that some of these clocks don't look normal. These are pretty obvious, right? And the thing is that each of the tests that are given, they're measuring something. Most of them are measuring more than one thing. So as simple as drawing a clock, not only are they measuring, the neuropsychologist would be looking for, how did they approach the task? Like, they didn't approach the task and clearly space it out. So the frontal lobes are probably having some difficulty, some visual spatial difficulty happening here. I'm guessing there's lots of perseveration here. The person just got lost on what they're doing and continued to go. So they're looking for all kinds of things, including, like, can they even set the time right? And so in one little simple test, that drawing a clock, you're looking at their planning, their approach, their organization, their ability to set the time. It's really a lot of frontal lobe functioning in this test, but this was just easy test for me to be able to show. I can't show you most tests for test security reasons, but this was an easy one to be able to show you that you can see things are clearly wrong. I actually think the clock draw test is going to be out of date soon, because we're looking at all digital stuff nowadays, and phones and iPhones, and the typical clock is kind of becoming outdated. But just so you know, all of the tests that are being done are measuring usually multiple things. Okay, and this video was really prompted by you, because I did a video a couple weeks ago on the difference between mild cognitive impairment and dementia, and how the doctor tells the difference between the two, and you wanted more information. So that's why I'm doing this video here today. And one of the important things I want to say before we dive deep into like the scoring is that many of these tests are designed to get harder the better the person does. So sometimes people will think they're doing really poorly, but the thing is, the questions and tasks are just getting harder because we're trying to test the maximum. We're trying to see how far can we get them, how much can their ability go before we stop. Now, it's not so cruel for most of them that we'll keep going when they're really, really getting hard. Usually there's a cutoff, meaning if they get a certain amount wrong, then we will stop it, and we don't tell them. Like, there's not a lot of communication during the testing process. So it's really hard for the other person on the other end to know whether they're doing right or whether they're doing well or whether they're doing not so well, because the evaluator is not supposed to be giving them feedback. Now, I will tell you from personal experience, doing dementia assessments and many people with dementia, there are things we can say and do to try to help calm them and keep them going with the testing. There is a skill to that. But for the most part, we're supposed to be very standardized. So the test can get harder the better that the person does. That's because we're trying to test how good and how far they can go. Now, the way that we know whether or not the score the person received is more in the normal range or in the dementia range, or maybe even in the mild cognitive impairment range, to make things simple, is that we use something called normative data, also called norms. So we have data of what is considered normal, meaning a bunch of people, normal, again, I'm using that word because it's called norms, normative data, have gone through these tests, people who don't have dementia. And then so now we have a reference points. And so we know that a person without any cognitive impairment should perform in this range. And when somebody is out of that range, it's a little bit of a red flag. Picture this example. So processing speed is something that decreases with age, meaning the older we get, the slower we become. So if I give somebody a processing speed task, and maybe I'm seeing how quickly they can connect some dots together, it wouldn't be fair for me to test a 45-year-old and an 85-year-old and then use the same data to figure out whether they're normal or not. That's not fair at all. The 45-year-old should absolutely be faster than the 85-year-old in most cases. That's also why normal is in quotes, because what is normal for one person is not going to be normal for somebody else. That's true when you consider age differences, education differences, and also race differences. So the normative data is really important, and the better normative data we have, the more accurate a picture we could get on whether somebody has normal thinking or dementia. So for instance, if we are testing a Black man with 13 years education who's 85 years old, I want to be looking at normative data that's as close as possible to that person. I don't want to be looking at normative data for a female with 5 years of education who's 23 years old. It doesn't make sense. It's not fair. So there's a lot of stuff happening behind the scenes that really doesn't ever get talked about when somebody is referred for neuropsych testing. It's not like we're giving you a bunch of tests and saying, do the best you can, and we'll let you know whether you're normal or not compared to everybody. We really are trying to compare it as close as possible to the person who's in front of us. What norms do we have that are as close as possible to that person? Now, I will say our norms are not perfect. Hardly any norms above the age of 85. And so when a 90-year-old comes and gets tested, we're using the 80 to 85-year-old norms versus the 90-year-old norms because maybe we don't have the norms for a 90-year-old on that specific test. And that's also key. Every single test has different norms to look at. And so just depending on the norms that are out there and what's available, the neuropsychologist or geropsychologist is doing their best absolute job to find what is closest. Okay, so now I want to move into how do you actually tell the difference? One of the frequent questions I received from you after I broke down the difference between mild cognitive impairment and dementia was, how do you tell the difference between the two? Let's pull up the criteria as a reminder of just how subtle the definition is. So let's talk about the difference between mild cognitive impairment and dementia according to the Diagnostic and Statistical Manual. I broke this really down for you in the video a couple of weeks ago, but just as a reminder, it's so subtle. Here we are in major neurocognitive disorder, which is considered dementia, and the very first criteria says evidence of significant cognitive decline from a previous level of performance and functioning. And if we look at the actual, that's major, so significant cognitive decline. And then if we look at the mild neurocognitive disorder, which is the mild cognitive impairment, it says evidence of modest cognitive decline from a previous level. So it's the difference between the words modest and significant. How does the doctor tell the difference between what is modest and what is significant? That's what we are going to get into. So when we talk about what is normal in dementia and what is not, this is called, I drew this, so please, it's not perfect, but this is the bell curve. This is the normal distribution of scores. And so when the doctor is looking at the scores, what we are looking at is pretty much anything in this area, for the most part, is normal. This is like average. So right here in the middle, this is where about 50% of the people would be. It's the mean, the average. And so we're looking for normal scores would be right around here. Right around here would be normal. Now, we have something called standard deviations, which is like how far does a score deviate from what is considered normal? How far does it go in either direction from how far it's normal? So if we have one standard deviation above the mean, we're getting more into the high average area. So if you're in the normal range, like right smack dab in the middle, you performed better on that task than about 50% of the population. If you were one standard deviation above the mean, above the average, then you perform better than 84% of the population. And here we'd be getting into more like above average, high average. If you performed below the mean, going anywhere down this way, you are performing less than average compared to the population. So one standard deviation below the mean is you are performing better than 15.9% of people. This still could be considered low average. This still could be normal. I'll give you a caveat on what's normal and what's not in just a second, because we are looking at the individual person. We can't just like treat all people the same. The real difference, like where the difference between mild cognitive impairment and dementia really lies, is going to be like right around here. So right around 2 standard deviations below the mean, 1.5 to 2 standard deviations below the mean and less, we're really being concerned for dementia happening. Again, there's more things being considered, but talking about test scores in particular, those are huge red flags for us. If we get to like maybe the -1, -1.5, here we're looking at mild cognitive impairment range. Here we're just looking at normal. Here we're looking like way above average. That's the breakdown. And that's what doctors simply don't have time to explain and share with you, is like how they're viewing it. -2 standard deviations below the mean for when somebody's being assessed. That means that person, if they performed -2 standard deviations below the mean, which actually happens quite a bit when people get referred for testing for dementia, because most people get referred for testing when they're already pretty far along in their disease process. It's not as common that people get referred in the earlier stages. -2 standard deviations means that person performed better than 2.3% of the population. So it's pretty impaired. So that's what the doctor is doing. They're taking the person's test scores on all of the different areas, and they're figuring out and plotting them along here. Where are they? And they're trying to make sense of it. Performance on certain tests will show patterns. So somebody with frontotemporal dementia will show a different pattern on testing if they're brought to testing early enough than somebody who has Alzheimer's disease dementia. Once somebody with any type of dementia, I mean, we're talking severe range dementia here. Once anybody gets to this range, it all looks pretty much the same because the brain is so impacted in all of its different ways. That's why the earlier you can get somebody tested, the better, so you can really figure out, okay, it's looking like this type of dementia. Also, it's helpful to compare over time, how quickly is it progressing. A lot of times when somebody is referred in the mild to moderate stages to get testing, they'll likely have a follow-up assessment in another year to compare the scores. So I know those tests seem silly. I know it seems ridiculous, but those are the tests we have, and they're measuring different parts of the brain, and then we can compare them to how other people are doing. Now, did you catch me say something about how maybe this is impaired, maybe it's not? So this is like low average range, not necessarily mild cognitive impairment, definitely not dementia. This is how we would know the difference and why AI and robots can never test for dementia until we get more biomarker testing, blood-based testing, things like that. As far as neuropsychological testing, it could never be replaced by a robot because you can't just give a diagnosis based on a score either. So I gave the example earlier. I think I said, a 40-year-old male with 8 years of education and an 80-year-old male with 13 years of education. Well, if we were giving a test that's a test of pretty crystallized intelligence, meaning it's not so impacted by dementia, at least earlier on, then we would expect somebody with 13 years of education. I mean, I would be concerned maybe if they were even in the average range. They're probably going to be more in the above average range. You want to look at their education level, their job, what would make sense for that versus somebody maybe with an 8th grade or 5th grade education level. If they were hovering around a -1 or even a little bit less, it might not be so big of a concern because for that task, which is really heavily relying on education, we would realize that person didn't have the highest level of education. That's actually probably normal for them. So even though this is the low average range, given their education level and what they did for work, that would actually be normal for them. Careblazer, does this help differentiate the difference between modest and significant? Modest impairment, which is mild cognitive impairment, is really going to hover around here. This is kind of the MCI, mild cognitive impairment, when somebody gets this. When somebody starts to show dementia, they're really going to be hovering around here. This much impaired, where they're performing better than only 2.3% of the population. Or when you get 3 standard deviations below the mean, you're performing better than 0.1% of the population. So all of this scoring actually So I know that testing takes a long time, but the scoring of the test takes a long time, probably, I don't know, maybe an hour to an hour and a half, depending on who's scoring and how well they are. And then it gets passed to the neuropsychologist who takes a look at these numbers and interprets them and puts together the big picture, just probably another hour, probably two, once you start adding the report writing on it. So it's a long process for the person who's being tested, but it's also a long process on the back end for the person who's doing the assessment and the report. That's why that's one of the appointments where you're probably waiting a month to get the results in a lot of cases. So I hope that sheds some light. I decided to do a video like this because I was seeing comments that while the dementia tips are helpful, and I won't stop doing those, it's helpful to understand more about the disease process because there's not a lot of time in the typical appointment to explain it. I would love to know from you, was this helpful? Does this help shed some light into what you or your loved one has experienced? And what other follow-up questions do you have? Leave them below this video. We read all of the comments, we really do. And we take a look at the ones that are repeated, the ones that have a theme, and we use that to come up with future videos. I am sending you so much love. If you haven't already, there's a free Careblazers survival guide that you can download, and it's over 60 pages of super helpful tips, resources. It will put you further ahead than most people if you just had this information, and I give it entirely for free. Also hit the red subscribe button to subscribe. It's totally free to do as well. It communicates to YouTube that videos like this are helpful for people who are looking for dementia help, and it will put my videos in front of those people. I really appreciate it. If you are looking for a community of support where you want to connect with other amazing Careblazers, you want to talk with me, you want to ask questions, you want to talk with other dementia experts, I would encourage you to check out our care course. All of these resources can be found on our website, careblazers.com. Sending you so much love. Bye.
Also, Nico gets a belly rub for every person who subscribes from this video. So if you haven't already, click the red subscribe button. It's totally free, and Nico says thank you very much.